Hello everyone, we are from Group 5. We will be presenting our case study titled of Spontaneous Right Basal Ganglion Bleed Secondary to Hypertensive Emergency. So this is our outline presentations. Moving on to our introduction, a 42-year-old male was brought to Hospital Simunjan after suddenly developing left-sided weakness at 10 a.m. on 26 October, followed by facial dropping and loss of consciousness. He was subsequently transferred to Sarawak General Hospital, where imaging confirmed a spontaneous right basal ganglion hemorrhage, and he was diagnosed with a hypertensive emergency. This case is particularly interesting because the patient was managed in a critical care setting, which presented several challenges in clinical observation and nursing assessment. His unconscious state and dependence on mechanical ventilation limited the ability to gather subjective information through interviews, while many medical interventions occurred rapidly or over multiple shifts, making it difficult to observe the full course of management. Additionally, he was on kangaroo feeding, providing an opportunity to explore the nursing consideration of enteral nutrition in a critical ill patient. Overall, this case highlights the complexity of care in neurocritical patients, the coordination required in an intensive care environment, and the practical challenges nurses face in providing safe and effective care. The patient Hamran bin Hassan is a 42-year-old Malay male who speaks Malay as his primary language. He has no known allergies and no significant past medical history. He was admitted to the hospital on 26 October due to a spontaneous right basal ganglia hemorrhage secondary to hypertensive emergency. This acute neurological event resulted in sudden left-sided body weakness, facial dropping, and loss of consciousness, prompting immediate medical attention and further management in a critical care setting.
Next, the chief complaint. A 42-year-old Malay male was brought to Hospital Simunjan after experiencing a sudden onset of left-sided body weakness at 10 a.m. on 26 October 2025. He subsequently developed facial drooping and later became unconscious. The patient was transferred to Sarawak General Hospital for further management, where he developed a hypertensive emergency secondary to a spontaneous right basal ganglia bleeding. For present history, during his stay in the Neurosurgery HDU, the patient developed continuous epistaxis likely related to anticoagulant therapy or uncontrolled hypertension. He later developed hospital-acquired pneumonia and showed poor GCS recovery and becoming unconscious. He also developed paralytic ileus with decreased bowel sounds. The abdomen was soft and mildly distended, and the patient had underlying liver cirrhosis, splenomegaly, and thrombocytopenia. On 20 November 2025, he was found to be hepatitis C reactive. Then, the past history. The patient is hypertensive, actively smokes, and is living their life as usual without any significant functional limitation.
Now, let us move to the body assessment. Generally, the patient was found to be unconscious and unresponsive upon assessment. Continuous monitoring was initiated. The patient was intubated and placed on mechanical ventilation using endotracheal tube with the size of 7.5 millimeters. On neurological examination, the patient's GCS was assessed as E1, VT, M1, which means that there is no eye opening, no verbal response, and no motor response. The pupillary examination revealed that the right pupil to be 3 millimeters, non-reactive, and left pupil 2 milliliters was reactive. On examination of the gastrointestinal system, the bowel sounds were noted to be poor, thus the enteral feeding was being administered through a RAS tube. On examination of the genitourinary system, a urinary catheter was in situ. The urine appeared to be yellow in color. For the integumentary system, there were no signs of head injury. The skin remained intact. However, it is noted that there is edema in the left limb. On the examination of the respiratory system, the patient was mechanically ventilated with the primary mode set to synchronized intermittent mandatory ventilation or SIMV. The ventilator settings included the rate of 16 breaths per minute, a tidal volume, a positive and experimentary pressure of 6 meters of water with the pressure support of 8 centimeters and a fraction of inspired oxygen. Additionally, the patient was alternated to continuous positive airway pressure or CPAP with the pressure support every 2 hours per shift. On the assessment of the areas of complaining, the active bleeding was observed from the patient's right nasal cavity during inspection. The examination of the left hand revealed visible swelling, and on palpation, +2 pitting edema was noted, indicating moderate fluid accumulation. It should be noted that the patient was unconscious and unresponsive at the time of the assessment, which limited the ability to obtain subjective feedback or assessor's responses to examination. It is revealed that there are significant abnormalities from the results of the clinical examination. The arterial blood gas analysis demonstrated a pH value of 7.28, indicating acidosis with a raised PCO2 of 56 millimeters mercury, suggestive of hypercapnia, and a PO2 of 116 millimeters mercury, showing adequate oxygenation on supplemental oxygen. The base excess was negative 2.1 millimoles per liter, which is consistent with slight metabolic acidosis. For full blood count, results show a white blood cell count of 13.21 times 10 to the power of 9 per liter. This indicates leukocytosis. The hemoglobin of 8.0 gram per deciliter and hematocrit of 24%, consistent with anemia, and a platelet count of 41 times 10 to the power of 9 per liter, indicating significant thrombocytopenia. As for the liver function test, it is revealed a direct bilirubin of 7 U-mol per liter, significantly elevated, which may suggest cholestasis. Albumin was low at 22 gram per liter, indicating of hypoalbuminemia and possibly chronic liver disease, while globulin was elevated at 45 gram per liter, potentially reflecting inflammation or chronic liver pathology. Hepatocellular enzymes were elevated with ALT as GPT at 86 units per liter and AST as GOT at 115 units per liter. This suggests hepatocellular injury and possible severe liver damage. Alkaline phosphate was mildly elevated at 146 units per liter, which may indicate the patients have a liver stress or cholestatic involvement.
Next is pathophysiology. Chronic hypertension causes prolonged vasoconstriction of arteries to regulate the blood flow. Over time, the arteries undergo arteriosclerosis, where its walls thicken and stiffen and become narrow due to plaque buildup, and the blood flow is restricted. The arteries become fragile and weaken, which makes it less able to withstand the high blood pressure. Since the structural integrity of the arteries is compromised, it can lead to the formation of microaneurysms called Charcot-Bouchard aneurysms in small perforating arteries in the basal ganglia, 80% of which is lenticulostriate. These aneurysms are highly susceptible to rupture. The sudden spike in blood pressure, which is the hypertensive emergency, increases the stress on the already weakened arterial walls and causes rupture. When a lenticulostriate artery ruptures, it causes intracerebral hemorrhage and creates a hematoma. The hematoma compresses adjacent brain tissues, causing neuronal dysfunction and disrupts motor pathways. Large hematomas increases intracranial pressure. The right basal ganglia bleed causes contralateral motor weakness, hence the left-sided weakness the patient experienced.
Next part is about management and outcome. This patient had done the right decompressive craniectomy, clot evacuation, and bone flap bury surgery following a traumatic brain injury that caused bleeding in the brain. For the pre-operation, our responsibilities are making sure the patient's condition was stabilized, to make sure the surgery is safe to proceed, and we need to make sure CT scan results confirm the need for surgery, guiding the proper surgical approach and decision making. We need to make sure blood pressure was successfully managed, reducing the risk of further hemorrhagic complication, and the family was well informed and consented to the procedure, ensuring the transparency and preparation. And lastly, the anesthetist confirmed that the patient was suitable for general anesthesia, ensuring safe peri-operative care. While for the intra-operation, our responsibilities are to ensure the airway is secured and oxygenation maintained during anesthesia, to continuously monitor vital signs and assist with medication adjustment as necessary, and to monitor fluid balance and blood loss, ensuring the adequate fluid replacement and blood products if needed. Lastly, for the post-operation, we need to regularly assess DCS, pupil response, and motor function for early detection of neurological changes. We need to ensure proper ventilation support, suctioning, and oxygenation monitoring. We can administer pain medication and sedative as prescribed to ensure comfort, and monitor the blood pressure, heart rate, and fluid balance to prevent further complication. We need to regularly change dressings and monitor for infection at the surgical and incision sites to promote healing and reduce risk of infection. And lastly, to offer emotional support to the patient and family, providing updates and reassurance. Next, for the medical management and the outcomes. The first management is ventilation and respiratory support. Patient is ventilated with SIMV, synchronized intermittent mandatory ventilation mode with FiO2 0.3, positive and expiratory pressure at 6 cm H2O to keep the airways open, tidal volume 420 mL, ventilator rate 16 breaths per minute. Patient is on tracheostomy to help in long-term ventilation and airway management. And the outcome is patient's SpO2 maintained within normal range and patient can breathe spontaneously with the pressure support. Second management is nutritional support. Patient is on NG feeding, which is kangaroo feeding 40 mL every 3 hours that will help to prevent gut atrophy and promote gut motility. Patient also has ongoing TPN with 1,904 mL per bag to provide necessary nutrients such as carbohydrate, proteins, lipids, vitamins, and minerals directly into the bloodstream. And the outcome is the patient is receiving adequate nutrition through TPN, no signs of malnutrition seen during hospitalization. Third management is hemodynamic support, which is noradrenaline infusion. Patient is receiving IV noradrenaline at mg in 50 cc of normal saline at 0.1 mic per kg per minute. It helps to manage hypotension, which may be secondary to the patient's brain injury or fluid shifts, also to help raise blood pressure and improve perfusion. Outcome: patient received adequate blood supply, not showing any signs of organ failure. And lastly, deep vein thrombosis, DVT prophylaxis, as patient is using the TED stockings and Venaflow, intermittent pneumatic compression that will help to prevent deep vein thrombosis. It helps to improve venous return, reducing the risk of clot formation in the legs, and the outcome is no signs of pulmonary embolism observed in the patient during hospitalization. Lastly, for pharmacological management, patient is on IV Keppra 500 mg to prevent seizures, improving neurological stability and reducing risk of ICP increases or further brain injury. No seizures observed on the patient. Patient also on IV Mesolan 10 mg, reduces nausea and vomiting, improving feeding tolerance and preventing aspiration-related complications, improve patient's tolerance to NG feeding with reduced nausea. IV Kiprofloxacin 400 mg to prevent or treat infection, particularly respiratory and bloodstream infection, reducing the risk of sepsis, and there's no sign of infection noted on the patient. Patient is also on esomeprazole 40 mg to prevent stress ulcer and gastrointestinal bleeding, supporting overall GI stability. No GI bleeding or ulcers noted on patient. Vitamin B12 given to the patient to support nerve function, red blood cell production, and overall recovery from neurological damage. And lastly, tablet vitamin C 1 gram that will help to enhance immune function, wound healing, and reduces infection risk, aiding overall recovery.
Good day. So today I will be presenting nursing care plan for our case study. So the nursing care plan 1, which focus on the patient with neurological condition requiring a close monitoring and intensive care management. The nursing diagnosis for this patient is ineffective cerebral tissue perfusion associated with increased intracranial pressure (ICP). This condition is secondary to a spontaneous right basal ganglia hemorrhage with hypertensive emergency. This diagnosis is supported by clinical evidence, including altered mental status, the need for mechanical ventilation, and the presence of arterial line for continuous blood pressure monitoring. The short-term goal is to maintain stable neurological status with no further deterioration throughout the hospitalization. The long-term goal is to prevent secondary brain injury and avoid worsening intracranial pressure, ensuring optimal neurological outcomes during the patient hospital stay. Several nursing interventions were implemented to achieve the goals. Continuous neurological monitoring, including Glasgow Coma Scale scores and pupil size, was performed to allow early detection of any neurological deterioration. Elevation of the head of the bed with natural head positioning was maintained to promote venous drainage and reduce ICP. Invasive arterial blood pressure monitoring via an arterial line was used to allow accurate blood pressure control and prevent rebleeding. Mechanical ventilation was provided to maintain adequate oxygenation and control carbon dioxide levels. to prevent hypoxia and hypercapnia, both which can increase intracranial pressure. Careful fluid management using prescribed intravenous fluid was implemented to avoid in short term. The patient neurological status remained stable with no further deterioration observed throughout the hospitalization. While in the long term, the patient did not develop secondary brain injury and showed no sign of worsening intracranial pressure during hospitalization. 3. Moving on, for this nursing care plan, they identified nursing diagnosis and effective airway clearance. This is related to a decreased level of consciousness and the patient's inability to protect the airway, as evidenced by the presence of tracheostomy, mechanical ventilation, and unconscious state. Due to this condition, the patient is high risk of airway obstruction and respiratory complication, which require close nursing management. The short-term goal for this patient is to regain and maintain patent airway as soon as possible. The desired outcome is to maintain oxygen saturation of at least 95% throughout hospitalization, indicating adequate oxygenation and airway patency. The long-term goal is for the patient to remain free from aspiration pneumonia and respiratory failure during hospitalization. This goal focuses on preventing serious respiratory complications throughout consistent and effective nursing intervention. So for the first intervention, mechanical ventilation via tracheostomy. This patient is supported with mechanical ventilation via tracheostomy. This intervention ensures adequate oxygenation and ventilation, especially since the patient is unable to maintain their airway independently. Intervention number 2, suctioning via tracheostomy as required. Tracheostomy suctioning is performed as needed to remove secretions. This helps prevent secretion build-up, reduce airway obstruction, and maintain airway patterns. Next, continuous cardiac and respiratory monitoring. Continuous cardiac and respiratory monitoring is carried out to observe vital signs and oxygen saturation. This allows for early detection of respiratory compromise and timely intervention if deterioration occurs. The fourth one is the monitoring ventilator parameter. Ventilator parameters such as peak pressure, tidal volume, and minute ventilation are close monitored. This ensures the ventilation remains effective and appropriate for the patient respiratory needed. Last but not least, semi-fowler positioning. The patient is positioned in semi-fowler position. This position helps reduce the risk of aspiration and promote better lung expansion, improving overall respiratory function. The short-term goal was achieved as the patient maintained patent airway with oxygenation saturation consistently at above 95% throughout hospitalization. The long-term goal was also achieved. The patient remained free from respiration pneumonia and respiratory failure during the hospital stay, indicating that nursing intervention were effective. Last but not least, the nursing diagnosis for this patient is the assessed fluid volume related to impaired fluid regulation and immobility for the third nursing care plan. This condition is evidenced by the left-hand edema, fluid intake exceeding the prescribed limit, and the presence of ongoing intravenous therapy such as IV fluid, TPN, or internal feeding. The short-term goal is to prevent the progression of edema and maintain fluid balance within the prescribed limits during hospitalization. The long-term goal is to prevent complications, particularly serious conditions such as pulmonary edema and increased intracranial pressure, also known as ICP. First, daily assessment of peripheral edema was performed. This allowed early detection and monitoring of the progression of the fluid overload. Second, strict intake and output monitoring was maintained. This intervention helped prevent fluid overload, reduce risk of cerebral edema, assist in controlling intracranial pressure, and prevent respiratory and cardiovascular complications. Third, compression socks were applied to promote venous return and help reduce edema. Fourth, the edematous left hand was elevated. Elevation reduced dependent edema by facilitating fluid return. Lastly, prescribed fluid and nutrition were administered carefully. This ensures the patient's natural needs are met while closely monitoring and controlling fluid loads. The short-term goal is to prevent the progression of edema and maintain fluid balance within the prescribed limits during hospitalization. The long-term goal is to prevent complications, particularly serious conditions such as pulmonary edema and increased intracranial pressure, also known as ICP.
Lastly, the risk of impaired skin integrity related to restricted mobility is evidenced by redness on the skin. Are the interventions and rationale? And this is the evaluation.